us today. I'll just give you a little bit of background about some of their clinical areas of interest and the path they took to get to our department. So first up will be Dr. Brad Miller. He started his medical training at the Medical University of South Carolina, where he got his MD and PhD in pharmacology, did his residency and fellowship training in endocrinology at Mayo before coming to the University of Minnesota in 2003, where he's been ever since. He's a professor in our department, as well as the division director for endocrinology. He has special areas of interest in growth and pediatric bone health. He also has become particularly interested in children with rare diseases and the adverse effects that they may have on their endocrine system. Dr. Paul Orchard started out his residency training at the University of Wisconsin Hospital System before coming here for fellowship in Hem/Onc and BMT, and joined our faculty in 1990. So we're so glad to have benefited from his wisdom and incredible clinical care in our department for many years. He really has come to focus on the use of hematopoietic stem cell transplantation for non-malignant inherited disorders, and we're going to have a chance to hear more about that today in his talk. He has been involved in multiple clinical trials and clinical protocols, and really has helped our bone marrow transplant unit to become an international leader in the treatment of non-malignant disorders with bone marrow transplant. So I'm really looking forward to hearing and learning from both of them today. Thank you for being here.
Excellent. Thank you, Emily. So we've divided our talk today into two or maybe three parts. One will be my early focus on adrenal insufficiency and adrenoleukodystrophy. Paul will talk about cerebral disease and adrenoleukodystrophy, and both of us will talk about how adrenoleukodystrophy can act as a model for clinical research in rare disease, and also talk about development of a rare disease center. So let me just advance my slide. Oops. There we go. These are my disclosures. We will be discussing off-label use of medications, since some of the medications are being developed and are not yet approved for use in children. The objectives are to understand the rationale and interpretation of results for newborn screening and adrenoleukodystrophy, describe the treatment options for cerebral ALD, and then recognize the components necessary for capturing and reporting natural history and treatment outcomes in children with a rare disease. So I'll start with some background about ALD. It is an X-linked metabolic disease caused by a mutation in the ABCD1 gene that leads to impaired expression of peroxisomal ALDP that is needed to transport very long chain fatty acids into the peroxisome for degradation. So the very long chain fatty acids accumulate to toxic levels, primarily in the adrenal and nervous systems. And the VLCFAs actually do not correlate with the phenotype, but they are the marker that we use for newborn screening. And I'll talk about that a little bit more later. We estimate the incidence of ALD somewhere between 1 in 15,000 to 1 in 30,000 males. And females who have a mutation in the gene can also be affected later in life. Primarily, we think of 4 categories of disease: those who are asymptomatic throughout life, those who develop adrenal insufficiency, cerebral adrenoleukodystrophy, and adrenomyeloneuropathy neuropathy. And individuals may have a combination of the last 3. 80% of boys at some time throughout their life have been shown to develop adrenal insufficiency, and that's where I'll focus my portion of the presentation. So I can't talk about the adrenal gland without talking about the feedback loop that involves the hypothalamus, pituitary, and adrenal axis, and how our body responds to stress. And it's particularly relevant when we talk later about newborn screening, since when you poke a baby to get blood, you actually stress them. And if we use ACTH, which is the primary stress hormone response that's acute, as a screening tool, we can get some false positives, and I'll talk a little bit about that later. But typically we think of the hypothalamus producing CRH, stimulating the pituitary to produce ACTH, and then cortisol produced by the adrenal gland, feeding back to the hypothalamus and pituitary gland. Endocrine issues in adrenoleukodystrophy can actually involve the 3 layers of the adrenal cortex, where mineralocorticoids are made, cortisol is made, or adrenal androgens are made. And the buildup of the very long chain fatty acids can cause a partial adrenal insufficiency or a complete adrenal insufficiency. I won't talk today about the impact on the testicle, but there's also hypogonadism that is a component of the disease. When we think about Addison's disease or adrenal insufficiency, we want to think about the symptoms that can occur, including chronic symptoms, fatigue, anorexia, weight loss, or poor weight gain, abdominal pain, and hyperpigmentation. And I think it's important to recognize that hyperpigmentation can happen in the areola, the genitals, scars, the gums, the palmar creases, and the general skin, as well as buccal mucosa, and then classic salt craving. We want to avoid adrenal crisis, and unfortunately, children can present an adrenal crisis with nausea, vomiting, abdominal pain, dehydration, hypoglycemia, hypotension, and altered mental status, and that can be life-threatening. And so we want to recognize a condition that causes adrenal insufficiency, or if individuals have adrenal insufficiency, we want to recognize a crisis and prevent it before it gets worse. So in grand rounds, we typically like to have a case presentation, and there's a lot of words on this slide, but what I'm just going to talk about is an 11-year-old boy who has been seen at our center, who was diagnosed with type 1 diabetes mellitus at 8 years of age. He presented with adrenal insufficiency after having poor school performance, growth delay, and skin hyperpigmentation. And you can see in the growth curve at the right that he had been tracking between the 25th and 50th percentile until about 8. And then his growth curve really decelerated down to the 10th percentile. He also had symptoms of ADHD, which didn't improve despite using stimulants and required an IEP. His family history is significant for an older brother with ADHD that didn't get better with use of multiple stimulants and had learning difficulties with loss of skills over time. Given his history of type 1 diabetes mellitus, his adrenal insufficiency was initially presumed to be autoimmune, and further diagnostic testing was not performed. But 11 months later, he had an MRI performed because of visual complaints and chronic headaches that revealed white matter T2 hyperintensity that is reflective of demyelination with GAD enhancement consistent with cerebral Ald, with a less score of 17, which Dr. Orchard will talk more about the scoring system, but basically severe disease. He was then found to have elevated very long chain fatty acids and a mutation in the ABCD1 gene that confirmed the diagnosis of ALD. And you can see on the right the hyperintensity that we were talking about. But unfortunately, the extent of his cerebral involvement was so severe that bone marrow transplant, which Dr. Orchard will talk about, would not be of significant clinical benefit. And so the patient has experienced progressive vision loss and remains at risk for continued neurologic decline, which could be ultimately fatal. And I want to emphasize the point that primary adrenal insufficiency in a boy, Addison's disease in a boy, should be considered adrenoleukodystrophy until it is proven otherwise. So any boy with adrenal insufficiency should be evaluated for ALD if it's obviously primary. Autoimmune adrenal insufficiency, which was suspected, is actually quite rare, even if other autoimmune diseases exist. In the setting of autoimmune polyglandular syndrome type 2, it's 1 in 20,000, which is similar to the incidence of ALD, but typically happens in the second and third or fourth decades of life, and more commonly in women. And so the likelihood in a child for autoimmune Addison's disease is actually lower than ALD, particularly for a boy. So as a group of pediatric endocrinologists, Dr. Srafoglu and I were part of a Pediatric Endocrine Society Drug and Therapeutics Committee, where we developed the Adrenal Insufficiency Action Plan, similar to the Asthma Action Plan. And so this is a tool that we use in the medical record with patients to show what are the regular doses of steroids, what do you do when you're sick, and what do you do in emergency situations and surgeries. So I just wanted to point that out, that that's something available. And work by our group partnering with Dr. Orchard and other people in the BMT team over time has actually looked at the clinical outcomes of children with adrenoleukodystrophy. And one of the things that Dr. Polgreen, Dr. Petrick, and the BMT team looked at and published in 2011 was, can identification of Addison's disease early actually improve survival and neurological outcomes? And so looking at 90 patients here at the University of Minnesota, they found that 79 had adrenal insufficiency, and that 17 of those adrenal insufficiency was the first sign of ALD. And they noted that if there was a delay in the diagnosis of adrenal insufficiency and ALD, that there was actually some increase in negative outcomes related to the condition. So they had 7 that had more than a year delay of diagnosis between Addison's and diagnosis of cerebral disease. And this is the punchline of the talk, showing that the functional scores in children who had early diagnosis were better, and after HCT were better. And those who had late diagnosis also had a significant higher value and got worse following the transplant. And so these values, the higher numbers are worse. And the same thing for the MRI severity score. Those individuals diagnosed early, pre and post transplant, did better than those who had late diagnosis. So a recognition that early diagnosis of Addison's disease can actually improve the outcome of adrenoleukodystrophy. Newborn screening, recognizing the importance of identification of CLD. Newborn screening for adrenoleukodystrophy was started in 2013 in New York, after Aiden's Law was passed following the passing of a young boy with ALD. And in 2016, ALD was added to the RUSP, or Recommended Universal Screening Panel, and Minnesota was one of the first states to begin screening the next year. So as I mentioned earlier, elevated very long chain fatty acids are that newborn screening tool that leads to additional testing and genetics evaluation. And Paul will talk later of how that system works in conjunction with our comprehensive adrenoleukodystrophy clinic. So Dr. Srafoglu and I worked with the Drug and Therapeutics Committee and Molly Regelman, who's a pediatric endocrinologist in New York State, to say, how can we identify children who have been identified on the newborn screening test to have ALD, who has adrenal insufficiency, and how can we catch them early? It's actually been identified biochemically as early as 5 weeks of age in an infant, and clinically in children as young as 7 months of age. So we set up a tiered system where the ACTH elevation was the key. If an ACTH was less than 100 on a random sample, we then looked at the cortisol value, which was obtained at the same time, and stratified it to say which categories should then go on to an ACTH stimulation test or just be diagnosed with adrenal insufficiency. And the thought is that if your ACTH is greater than 300, you're basically maximally stimulating the adrenal gland. And if you can't make enough cortisol in that situation, you have adrenal insufficiency and should start treatment. Otherwise, if your ACTH is low and your cortisol is normal, then we want to continue monitoring. And for children less than 2 years of age, because we don't have it's harder to identify symptoms of adrenal insufficiency, we recommended screening every 3 to 4 months. And as children get older and have more recognizable signs and symptoms, we decrease the frequency. And then after the peak period of adrenal insufficiency development, started looking annually. So this is an example of a guideline that we are trying to put in place based upon expert evidence and previous history, that as newborn screening becomes available, can be tested and shown whether or not it works. And so earlier this year at the Pediatric Endocrine Society meeting, our group looked at our results for the last several years since newborn screening started. We had 21 boys who had data available, 104 ACTH and 99 cortisol measurements. The ACTH mean values were 43.3 and cortisol was 8.7. And the this is months. I'm sorry, it says age in years, which threw me off. This is actually months. And the ACTH value was greater than 99 in 10 of those children, the cortisol less than 10 and 64, and meeting both criteria for a stimulation test of an ACTH of 100 or more and a cortisol less than 10 resulted in two children. And these are those kids who actually had an ACTH stimulation test. I mentioned there were 2 that met the criteria, but there were also others that were done for clinical concerns. And out of this group, 2 children had a peak cortisol less than 18 in response to the ACTH stimulation test. So we're identified with adrenal insufficiency and then started on either stress dose steroids or stress and maintenance dose steroids to prevent adrenal crises in the future. So the diagnosis of adrenal insufficiency of the boys less than 3 years of age seen here at the University of Minnesota, we had 2 boys identified, or 9.5%. One boy was 11 months old when he failed his stimulation test, but it actually had elevated values ranging from 107 to 190 since 3 months of age. The second patient at 31 months also failed the test, but had marginally elevated values starting at 2 years of age with further elevation over time. And as I mentioned earlier, the ACTH being a stress hormone makes it difficult to use as a screening tool. And so we're trying to identify other adrenal markers that might be beneficial in that area. And I want to make sure people recognize that neither patient had any evidence of hyperpigmentation or symptoms of adrenal insufficiency at the time of diagnosis, which shows that we caught them early and prevented worsening of disease. And there may be some evidence since ACTH elevations predate cerebral disease that there could be a connection, that the ACTH might actually encourage the development of cerebral disease. So historically, almost 80% of boys diagnosed with adrenoleukodystrophy develop it between the ages of 3 and 10 years. Often it's not recognized until the time of diagnosis of cerebral disease. Our prospective monitoring protocol has identified boys as early as 3 months with abnormal labs, and about 10% of kids identified before the age of 3. And it's important that we have early and periodic monitoring for boys to avoid the morbidity and mortality due to adrenal crises from unrecognized adrenal insufficiency in the patient population. So I want to transition in the last few minutes of my portion to talk about how can we translate this experience into research tools for rare disease. And so I want to acknowledge that rare disease multidisciplinary clinics are important for clinical research. You have a unique cohort of patients to develop, which can allow for collaborations and investigator-initiated research, participation in natural history studies, participation in industry trials or registries, and the potential to generate both RVUs and indirect costs. So it's an important money tool for a university system as well, as a very important thing to help understand the condition to allow better therapy. And I'm just going to give a quick example of the grants that we've had in our division of endocrinology, currently active with Kiki's CAH clinic. Kiki also is involved with hypophosphatasia clinic, Turner syndrome clinic, inborn errors of metabolism clinic, and these are all grants related to that. Melina Bellin has 3 RO1s, 2 UO1s, and a UC4 grant that are related to chronic pancreatitis and total pancreatectomy and auto islet transplant. Cystic fibrosis, Dr. Moran, looking both at CF and CF related diabetes. And then I have a grant with the Kids First Foundation related to the development of Fanconi anemia growth charts. So this is really an example of how our division is involved already in multiple rare diseases. And in the last 5 years have published nearly 100 papers in this area from our group. And so as I look at that, I recognize that we're already doing well at understanding rare diseases, but there are some holes, and Paul will talk about things that we need to improve both the care of children and adults with rare diseases, as well as the research efforts and community efforts that we have. So I'll turn it over now to Paul to talk about Cerebral Ald and the rare disease efforts that we have ongoing.
Great. Thanks, Brad. Thanks, Emily and Joe as well. All right. Hopefully everybody can see this. So in terms of disclosures, most of the support that we have is essentially in association with clinical research and clinical trials. And so, and one of the companies I want to kind of point out is Orchard Therapeutics, which is not my company. But I'd like to talk about a bit today, a little bit of background of how we got into treating ALD with transplant, talk a little bit about the transplant outcomes. We've also been involved in lentiviral gene therapy protocols for adrenoleukodystrophy, and I want to talk about that a little bit. And then the National Registry for ALD is based here, and I want to discuss that briefly, as well as some discussion of the comprehensive ALD clinic that a number of us are taking part with or in, and then the implications for this. So this, in terms of transplant for metabolic disease, this is actually the first report, and so the beginning of things here at Minnesota. So we're the first center in the country to transplant patients with these types of disorders. This is a lysosomal disorder, MPS 6 or Meritolame, but adrenoleukodystrophy followed after this. But one of the important pieces here is that Bill Crivet, who was on the ground floor of doing this, and Elsa Shapiro as well, put in a grant to do long-term follow-up studies for these patients that are transplanted. And this really helped set up the infrastructure for us and positioned us to be a leader as an institution for these diseases. So why are we still transplanting patients with these types of disorders? So all these genes, of course, have been cloned. You can make pharmaceutical grade products for these things. So what's the role of transplant? And so there's obviously differences between various types of diseases, lysosomal disorders versus peroxisomal disorders, and ALD is a peroxisomal disorder. But in general, a lot of the molecules that one uses, such as enzyme, does not penetrate into the head very well. And so it's really insufficient as therapy for neurologic types of disorders. But following allogeneic transplant, where you have donor-derived cells, they can make their way into the brain and actually serve as a mechanism of treating the central nervous system. So most of the disorders that we're treating with transplant really have a neurologic component to them. I want to talk a little bit about where we are as an institution in treating some of these disorders. And ELD, of course, is the focus this morning, but I want to talk a little bit more broadly about things as well. So there's a group called Be the Match, or the National Marrow Donor Program. They're the group that helps us find donors, essentially, for people that need to be transplanted, but they keep track of who gets transplanted where for what. So we looked at their database to find out what institutions are actually transplanting adrenoleukodystrophy. And there's 152 centers in that data analysis. And we, as a single institution, have transplanted 27% of the patients with ALD. Similarly, if one looks at the total numbers for metabolic disorders, and again, same data set, 152 centers, we transplanted 21% of all the patients with these types of disorders. So I just show this to show that the University of Minnesota has really been a leader in the use of cellular therapy and transplant for these types of disorders. This is data actually from our own institution in terms of the pediatric transplant experience. So the last 5 years, the green bars are the total numbers of transplants that have been done by the pediatric blood marrow transplant group, and the yellow or gold bars are the metabolic patients. So one point from this slide is, and this doesn't include some of the other rare disorders like Fanconi or dyskeratosis or SCID, for instance. But just on the metabolic side, about 24% of the patients on average have these types of rare disorders. And the other point I want to make with this slide is that these aren't our patients in terms of Minnesota-based patients. 87% of the patients here have come from outside of Minnesota. So we're a national and actually international referral base. So Brad had a similar slide. I'm not going to go through this in a whole lot of detail. I'm going to focus on the cerebral side of the disease in my section of the talk. So there are a number of phenotypes, as was pointed out by Brad earlier. So there is adrenal neuropathy, which tends to happen as patients get older, adrenal insufficiency, and the cerebral form of the disease. So you can have any of those phenotypes or all of those phenotypes. And this just gives you a sense of what has been the experience in terms of developing a phenotype as patients get older. And again, this goes through the various proportions of the phenotypes and the ages of onset. In terms of transplantation, though, cerebral ALD is really been the focus. So this is the group I really want to talk about. And up to age 21, about 40% of the boys develop the cerebral form of the disease. This is the natural history for untreated cerebral ALD. So by 8.6 years, 50% of these kids are dead. And this doesn't obviously include the cognitive aspects, the motor aspects, and these other types of things. It's a debilitating, progressive, lethal disease. There's a lot of things we don't understand about ALD. There's a peak in childhood. This is a clinical peak, is about age 7. We don't know why that is. There's within a family with the same mutation, there are kids that get cerebral disease and there are those that don't. So we really can't predict based on the mutation or even the family history who's going to develop cerebral disease. So there's clearly factors here that we need to better appreciate. One of the other parts of this is that even into adulthood, people can get cerebral disease. And we partner with our adult bone marrow transplant group. So if there's a patient that's older than we can transplant on our side, they will transplant those patients as well. This is what the disease looks like. So it's a demyelinating white matter disease. About 85% of the cases are occipital, tends to begin in the area around the splenium and progress from there. You can see on the right side here that there's a significant amount of occipital disease. It tends to affect vision, understanding of language, and then as it expands, more motor related issues. On the right, so gadolinium is one of the contrast materials that we use for MRI imaging. Gadolinium is not supposed to localize into the brain. And if there's active inflammation or anything that breaks down the blood-brain barrier, it will allow gadolinium to localize. So as you can see here, there's a rim of gadolinium enhancement, which is associated with neuroinflammation. It's a neuroinflammatory disease resulting in essentially death of white matter. Brad alluded to this as well. So there's a scoring system that was developed called the LESS scoring system. Dan Less is a neuroradiologist that was here at Minnesota. Essentially, the scoring system, you get a point for each area of the brain that's affected in terms of white matter. So the more points you have, the more advanced your disease is. So the scoring system was developed almost 30 years ago, but this is widely in use yet, and it's been actually really important in helping stratify patients, primarily into more standard risk patients versus those that have more advanced disease. And depending on the report, a publication, score of 8 or 9 or 10 generally is the cutoff between standard risk and advanced disease. So this is our data in terms of overall survival with cerebral ALD, 76%. However, I wanted to point out again, based on the degree of advancement of the disease, it makes a significant difference in terms of how you do. And this obviously is survival, and the patients that have more standard risk disease, so a less score that is less than 10, their outcomes are clearly better than those that have advanced disease. But this is just survival. And we also look at neurologic function and neuropsychologic outcomes as well. And I don't have time to go through all those things today, but those pieces are clearly important for these patients also. And all of those are related to the amount of disease that you have coming into transplant. I want to talk a little bit about the gene therapy approaches. And so this is sponsored by a company called Bluebird Bio we've been active with. So this is a bit different. So on the left side here, we go through initially the process after identifying a patient that might benefit from the procedure, but we isolate their own blood stem cells, the CD34 positive cells. And we use a process called apheresis to do that. Those cells are then shipped to the manufacturing site. They use a lentiviral vector that's got the ABCD1 gene in it. The cells are then frozen, and there's about a 4-week period to do the quality control and make sure that the transduction procedure has gone well and there's no infectious issues, whatever. So that takes about a month. Then they will call us and say, okay, we're good to go. Patients come back. There's actually 2 studies, and I'll go through this a little bit, but the patients still need to get conditioning in terms of chemotherapy because we have to eliminate the blood stem cells that have not been corrected, and then the cells are infused. And the idea is that these cells that are now expressing ABCD1 can make their way into the brain and help stop progression of the disease. So the studies essentially are 2-year follow-ups looking at neurologic outcomes and imaging and a variety of various things. And then the FDA has mandated actually at this point that all these patients that are receiving gene therapy be followed for a total of 15 years. So there's a long-term follow-up study that's dovetailed to this. So there are 2 studies, and I'm not going through all this information certainly, but the first study was called ALD 102, the StarBeam study. That's been closed for some period of time now. Both of these studies, and the more recent one is the ALD 104 study, essentially the same population of patients. You have to be a pediatric patient. You have to have white matter disease. You have to have gadolinium positivity, suggesting that you have active neuroinflammation. And that's kind of defined who may benefit from this. The first study used busulfan and cyclophosphamide. The second used busulfan and fludarabine. And then they monitor the patients in terms of, as I mentioned, imaging, the functional scores, the gene therapy specific outcomes in terms of vector copy number and whatnot. And then basically for toxicity, how fast do you engraft afterwards, et cetera. So these are the institutions that were on the more recent study, the 104 study. There's 8 of them, 3 in the US, 3 in Europe, and in Australia and in Argentina. and just a little bit of the background on how these patients have done. So the data cutoff here is actually quite old. And so more recent data isn't incorporated into the slides that I'm going to show you, but I can't show you the more recent data until it actually gets published. The 32 kids infused on the first study, 3 of those came off study. 1 progressed enough that he actually just progressed and died, and 2 progressed and went on to transplant. But outside of that, the patients have all remained on study. The 104 study actually has now hit accrual. There's 35 patients been on that study, and again, the data here is only partial. Some of the gene therapy specific outcomes. So they look at vector copy number, for instance, what's the average number of vector copies per genome, essentially. It's a little different number, the proportion of the cells that actually have picked up the virus. So that's the LVV positive population. It's interesting that the 104 group seems to be a little bit higher, although I don't think statistically different. The cell doses of the number of CD34s that are infused, and there's the time to engraftment for neutrophils and platelets here. This is the MRI scores over time. As you can see, that one patient that is at the top there was the one that progressed and died. But in general, the LES scores have been reasonably stable over time. The safety profile has been quite good. So there have been, again, in the first study, 3 of the patients were taken off study for progression. But there's one of the outcomes that they use is in terms of major functional disabilities, or MFD. That was kind of a binary endpoint that they came up with, which really reflects quite extensive neurologic disorder or difficulties. And no one has achieved that outside of those 3 patients. Just in general, if we compare this to allogeneic transplant, auto transplant with lentiviral corrected cells is certainly easier. We don't have to use immune suppression. We don't have to worry about graft versus host disease. We don't have to worry about graft rejection. One still sees issues in regards to the chemotherapy. There are a few patients that got, for instance, hemorrhagic cystitis and prolonged pancytopenia, but really no one has died going through the actual transplant process. So, as I mentioned, there's certainly risks associated with lentiviral gene therapy. Some of these may be late events, such as development of leukemia following the infusion of these cells, but that may take years to really better understand what that risk is. Certainly, though, in the peri-transplant period, out to day 100 or so, the risks are significantly different. It's probably about 15% mortality rate with allotransplant. It's probably going to be more like 1 or 2% with an autologous approach. So the studies are closed, as I mentioned, to accrual. They're actively pursuing licensing in Europe. The EMA is kind of the FDA equivalent in Europe. And it's, I think, highly likely that that will get approved, maybe even in the next few months. In the US, it will follow likely in 2022. One of the issues here is going to be important to recognize is that we don't really know what they're going to charge for this yet, but it's likely to be significantly more expensive than transplant, in the $2 to $2.5 million range. And it's also important to recognize that, as we talked about, this can occur, cerebral disease can occur in adults. There were no adults in the study. There were no advanced patients in the study. So some of these other populations would be important to look at. So what's the future going to look like in understanding and treating ALD? Brad mentioned newborn screening. I think this is quite up to date. So there's a significant lag time in getting newborn screening off the ground in states. So it was added to the RUSP, ALD was in February of 2016. There's only 19 states that are screening. Well, actually, plus DC, I think, is screening as well. So it's taken a long time for a lot of the states to begin to screen. And this is really unfortunate. I wanted to talk a little bit about the national registry. So historically, virtually all the patients with ALD that we've seen had cerebral disease. They're referred to us for transplant. But now we have the opportunity, because of newborn screening, to be able to monitor these patients in a longitudinal manner and help better understand why the various phenotypes develop and what we might be able to do to better understand the biology of this, but also be able to intervene early. So we developed the ALD National Registry. Ashish Gupta is actually the point person for this. It's here at Minnesota. It allows us to gather information on a national basis for patients that are diagnosed with ALD, pick up their laboratory information, other medical information, actually imaging, so we can compile that here. There's a biorepository built into this. Troy Lund is in charge of, and will allow us to look for biomarkers. We're also, as part of the registry, going to gather more data on adults with ALD. So the men that have AMN and some of the females as they get older that are carriers can develop symptomatology as well. So we need to better understand that also. Been over 100 patients registered so far, and we had another, just learned in the last few days actually, that we're going to be supported again for the registry through the Association of Public Health Laboratories. So the way this actually works, so this is not a physician provider-based registry. This is a family-based registry. And the electronic process of registering the patients is depicted here. So we need to get the word out to people about the registry. So advocacy groups are going to help us with that, the social media platforms, word of mouth, and the patients that are coming to us in our own clinic are going to be offered the ability to sign up for this also. But essentially they go on a website, there's an intake form that they fill out, they then get an electronic consent, and that allows us to do to send surveys to the families and to access their medical records and to get their MRIs and specimens as well. So essentially it's a couple of phases. The first one is they enroll. There's again a survey that they fill out that's fairly extensive about how diagnosis was made, et cetera. Then we can access their medical records. Whatever MRI-based imaging is available, we'll be able to access and compile here. And then we'll be able to start getting specimens. And then every 6 months, we're going to reach out to the families again, get follow-up surveys and any additional information regarding ER visits or hospital visits or development of a phenotype, for instance. So one of the other things that we thought would be important to mention today is that, so this is a complex disease, and none of the families that are picked up by newborn screening are somewhat on their own to be able to get the monitoring that they need. And we think it's really important to be able to offer essentially one-stop shop for these families. So we put together a multidisciplinary clinic structure to allow us to do that. There's a genetics presence there. Nishitha Pillai is important there. Bill Dobbins as well. Rebecca Tryon is our genetic counselor. She does a great job. We're integrating both pediatric and adult neurology into the clinic. Rini Pierpont's the point person for the neuropsych group. Brad on endocrine, and then some of us on the transplant side as well. So we're building this clinic to better serve the patients and allow us to use that as a platform to do research. This is another case study, essentially. It's a family study. But just to give people some perspective, so adrenoleukodystrophy is an X-linked disease. Most of the diseases we screen for are recessive. But because we can pick up an index case by newborn screening, one can then look throughout the family and help identify others that are at risk. And as you can see, very extensive pedigrees can identify a number of people throughout various generations that might actually be at risk for problems. And then this will allow us again to pick up patients earlier and potentially intervene earlier if necessary. So the data that we've got on newborn screening in Minnesota thus far is, I think it's at least 3 other individuals have picked up for every proband that's picked up by newborn screening. I'm not going to go through this in a lot of detail. The idea is, though, to develop a structure for monitoring for the patients such that we can pull all this together within the clinic. So there's genetic counseling and genetics associated with it, monitoring for adrenal insufficiency, monitoring for cerebral disease with MRIs, and looking at adrenarche as well. The neuropsych evaluations are integrated in this as well, and then the bone marrow transplant group too, in case that ends up being an issue. So another piece to this, and virtually all the patients that have been picked up in Minnesota are part of this clinic, but a number of families are actually coming to us from outside Minnesota because we have this integrated clinic, and it's allows the families to get the information that they need in one place. But it also serves as a platform for us to do clinical research. I think virtually every patient that's coming to our clinic has signed up for the registry. As part of that, the biorepository, the MRI-based imaging, and data management is key here. And the people that are involved in those things are listed here. Igor Nestersil is doing novel imaging, offering that to families as an independent clinical research protocol. And Rini Pierpont is also developing things from a neuropsychologic clinical research side. Yep. There we go. So we have a number of strengths at Minnesota, I think, is hopefully we made plain. We've got a prior history of expertise in these types of disorders, and I'm going to talk about this a little bit more broadly now. ALD is a prototype for developing a new model for care and for developing research. And the clinical trial infrastructure here is strong, which is important for us. We've got a number of interactions with industry that will help allow us to be able to offer novel therapies. There's great basic science here. John Wagner is running the Institute for Cell, Gene, and Immunotherapy. There's a Center for Genome Engineering. And so there's very good basic science. Chet Whitley's had a grant for gene therapy for a number of years as well. The Masonic Institute for the Developing Brain is going to open its doors, I think, relatively soon. And I think we've come a long way in helping the leadership at the institution understand the importance of rare diseases. So what we'd like to be able to do is build a center of excellence in rare disease. And we need to put together the infrastructure to be able to do this, be able to integrate the clinical care and the research into one under one umbrella, essentially, rather than have it be a bit siloed throughout the institution. As part of this, the National Organization for Rare Diseases, or NORD, has relatively recently, several months ago, announced that they would designate sites as centers of excellence for rare disease. So there's an ongoing initiative to put forward a protocol from here, or information from here, to be considered as a center of excellence for rare disease. Sue Berry is heading that. Sue can't be here today, so I think Bill Dobbins is going to be here, and he can speak to this as well. But we're trying to work together to put all these things in one place, be able to put our best foot forward and present that to NORD, but we also want to present it to the powers that be here at the institution to help them better understand what we need to put together. So I will stop there. Thanks everyone for for your attention, and we can open things up to questions.
And Dr. Dobbins, if you're here, please feel free to join us on screen here for questions or comments.
Yeah, my video, I'm here, but my video is blocked. So, but you can hear me.
Great.
Yes.
There he is.
So I think the first thing to talk about this is that the proposal that we're putting into the National Organization for Rare Diseases to be named as a center of excellence is important. Doesn't come with money, unfortunately, often the case, but it is going to come with some major catch-it, and I expect that will pull a significant number of more patients with rare diseases into the system here. Many of you have already heard from Sue or from Brad or Paul, because we know that you are treating rare diseases. If there are others of you who we have not reached out to yet, so Sue is out of town, but please email me with a CC to Paul and Brad, and we will make sure that you get pulled into the effort, which is coming to a head probably within the next 2 to 3 weeks.
And that effort, as Paul mentioned, is centered around the designation from NORD, but this is going to be an ongoing effort to try and bring together the work around rare disease under one center and governance and support structure. And so I think Sue will be the point person for that, but we have multiple people in our department who are interested in supporting that effort.
And I might just mention too that as going through this exercise of being able to pull all this information together, that by itself has been very useful. So we're talking primarily about the pediatric side of things now, but this is cross departments and actually even cross colleges. So for instance, Jim Cloyd, who's in the College of Pharmacy, is very interested in orphan diseases and what they might do from that standpoint too. So I think it's been really important for us to get a better understanding of really who's in this space in the university and be able to compile that all together.
Yeah, and Fairview Specialty Pharmacy as a rare disease designation as well because of the care that they provide. Paul, there's a question in the chat from Dr. Neglia about animal models. Have they provided information about the distribution of genetically corrected cells in the CNS, and what is the penetration and how stable is it?
Yeah, so that's a complex question. So in terms of adrenoleukodystrophy, actually the models are not very helpful. So there is a knockout mouse, and they accumulate very long chain fatty acids. So metabolically, chemically, they look analogous to what we see in the kids, but they don't develop cerebral disease for whatever reason. So it's not really been helpful from that standpoint. There is a lot of interest in how we can augment cell localization to the brain, and Troy Lund's got actually an active research program going on in looking at how to do that. Because I think if we can better understand how these cells actually cross into the brain parenchyma, where they go, and what factors influence that, I think that'll give us a better opportunity to intervene. Because it's been, frankly, it's been kind of a black box. I mean, people have thought for a generation that this is really how enzyme is delivered, for instance, after transplant, but it's very little we understand in terms of how that actually takes place and which cell types are important and how to, again, better facilitate their getting into the brain. So be important information, but we don't have all the answers.
And I wanted to emphasize, you had said earlier about the patient advocacy groups and partnering with them. There have been a number of groups supporting Troy's work and supporting the registry. So I think it's just an important partnership that has already been engaged, and I think Troy has been very active with that as well.
Yeah, it's important to understand too. So, as Emily pointed out, I've been here for a really long time, but when we really got started doing some of these things, virtually all of our referrals were physician to physician referrals, and that's just not true anymore. And a lot of the patients come to us via the advocacy groups, or they pick up something on a listserv, or they're just looking at websites or Facebook even for that matter. So a lot of our referrals now are self-referred. And we don't, I certainly don't appreciate how to optimize those kinds of things either. But as we're have new therapies to be able to offer, being able to get the word out is really important, and better understanding how to do that would be useful for us.
Great. Looks like we're at time.
Ding, here I come. Yeah, I'm totally fascinated about the social media outreach aspect, because I think that is such a new frontier in getting patients to the right place for their care. I am a stickler about ending on time to be respectful of people's next activities, but I was really intrigued by the ADHD that doesn't respond as expected as being having ALD on our list. So I'm going to send the two of you a question afterwards.
And include Rini Pierpont on that question, as she is an expert. But thank you.
Yeah.
Wonderful. Well, thank you both. That was a really just wonderful talk with, I learned a ton, as I always do during grand rounds. I hope everyone was able to log your attendance. Thanks for bearing with us as we're trying a new system, and have a wonderful Wednesday.
Thank you, Emily.
Thanks, everyone.
And
Bye,
it does
everybody.
work.
Thanks.